talk about pain. Pain is a really crucial concept to nursing, one of the most fundamental. If you accept the philosophy of nursing as being concerned with the experience of the patient, as opposed to, say, medicine, which tends to focus on healing of the body and organs, whereas nursing is mainly concerned with the experience of the patient in health, illness, and treatment of illness, pain is one of the most crucial concepts because it all has to do with patient feeling, physical and emotional. We're going to be mostly talking here about physical pain. It's important to understand that physical pain is a process in the body in which there's some sort of injury to the skin or one of the tissues inside the body, either a mechanical or chemical injury, pressure, which then goes through certain phases to become what we call pain. So first, there's transduction, where that injury gets changed into an action potential in the nerve that brings the message of pain towards the brain. When that nerve message of pain gets from the periphery to the spinal cord and then to the brain, that's called transmission. Within the brain, the recording of that pain signal is called perception. So how we perceive the pain that we're experiencing. That has to do with a functioning conscious brain as far as we understand pain. And then there's a fourth stage in pain called modulation. Modulation is what our body may or may not do to decrease the pain or mollify the pain. So things that our body can do to inhibit or mollify pain responses or even block them. Neuropathic pain, on the other hand, as opposed to the nociceptive pain, is pain that's really coming from nervous tissue itself in the nervous system and or an abnormal processing of the pain signal. So maybe there's no actual injury at all, but our nervous system is hearing or interpreting something as pain. That's neuropathic pain that emerges from the nervous system itself, either the nerves themselves, the spinal cord, or the brain itself. So, for instance, herpes zoster is infection along the nerve itself. It's quite painful, or what's sometimes called phantom pain is another sort of neuropathic pain. When someone has an amputation, but they're still feeling pain from the limb that's missing, it's because the nerves that used to run to that area are still being stimulated. The nerves themselves are still being stimulated. So the message to the brain is exactly the same message that would be pain if there were still a limb there that were being injured. Now, there's a number of different ways that we can categorize pain. For instance, visceral, deep somatic, cutaneous, and referred pain. Visceral pain comes from the larger internal organs, like pancreas or gallbladder, and somatic pain comes from the musculoskeletal tissues. Deep somatic pain comes from tendons, muscles, or even the bone, joints. Cutaneous pain comes from the skin, cutaneous meaning the skin. Probably the majority of pain in a young person would come from the cutaneous area. If I poke you in the arm, that's cutaneous pain. Referred pain is a kind of pain that starts from injury or disease in one area of the body that's perceived as coming from another area. So, for instance, an ectopic pregnancy might be damaging a fallopian tube, but it can actually be felt as pain in the shoulder. For some reason, I'm not quite sure. But there's a number of different diseases and conditions like that that tend to refer pain to another area. So the patient is really experiencing that pain. It's real pain, but the issue or the damage is actually in an area different from where they're perceiving the pain. Probably the most crucial thing to understand about pain is that it's defined by the patient. It's not for me as the nurse to say how much pain my patient is experiencing or if they're experiencing pain. It's only for the patient to say. And how bad their pain is, it has to do with their perception and nobody else's. This is a concept that'll become really important later. Now notice that perception of pain is a crucial component, and this becomes really important in nursing interventions for pain. So for instance, if we can successfully distract our patient or make them happier by whatever means, they're going to actually have less physical pain because their perception of that pain is a crucial component of the experience. We know, for instance, that people who are feeling more anxiety or less in control experience more pain. And it has to do with psychological aspects of pain, which are very real and also often present really helpful moments and ways in which a nurse can intervene to increase their patient's comfort and decrease their pain experience. Another way that's important to be able to categorize pain is acute versus chronic. Acute pain is pain that tends to be protective and short-lived. So if I step on a tack, I have a sudden, sharp pain, hopefully, if my nerves are all intact, and it serves me by helping me protect my foot against further injury, alerting me that there's an injury, that there's something dangerous there. That's usually self-limiting pain. The pain from the attack may hurt for a little while, but it's going to resolve. Chronic pain, on the other hand, is pain that goes on for more than, usually we say, 6 months. So arthritic pain, some cancer pain, things like that. In this case, that pain isn't protective for the patient. It doesn't really help them avoid a particular situation. It just decreases quality of life. Within chronic pain, we tend to differentiate between malignant and non-malignant pain, which simply stated, malignant means related to cancer. There's also something called breakthrough pain. Breakthrough pain is a phenomenon in which a pain that is normally controlled from, for instance, pharmaceutical intervention, a pain reliever like acetaminophen, ibuprofen, a narcotic. The onset is for half an hour. It works to control the pain, and then it starts getting metabolized out of the system. And before that patient gets another dose of that medication, the level in their body isn't high enough to actually control the pain anymore. So now we have breakthrough pain between doses. That's an important concept because oftentimes we can adjust things, if not dosing, routes, or change their pain control regimen so that we can decrease breakthrough pain. So when someone has pain, or really any symptom at all, we're going to do something called a full symptom analysis. This is a really important concept that we're going to come back to again and again and again in this course. It has to do with getting a good history, all the aspects, all the important aspects of a symptom that help us understand what it is, what it might be related to, and how to deal with it. There are a couple of different common ways of organizing a symptom analysis. One of them is using the alphabet, starting with O for onset. When did this pain start? Or other symptom. You could use this for nausea, stiffness, forgetfulness, numbness. Pain is sort of the classic symptom, and it's the easiest one to do a full symptom analysis of, you'll see. Onset means when did this pain start? P refers to palliative or provocative factors. What makes this pain worse? What makes this pain better? Does walking make it better or worse? Does ice make it better or worse? Does rubbing it help? Certain medications? What triggers it as provocative factors? Certain activities, foods, psychological conditions, stress. Q is the quality of the pain. We want our patient to describe the pain. Is this pain burning, searing, achy, dull, throbbing? Try to use a descriptor like that, an adjective that helps describe the pain. That can really help us understand how to diagnose what's going on. R is for region or radiation. Where exactly is the patient experiencing this pain? Where on the body, and not just the elbow, but where on the elbow. Not just the head, where in the head. You're going to use all your fancy anatomical nomenclature language to precisely describe the location. And does it move? Is that pain radiating into a certain area? So maybe the pain starts in my glute area, but radiates down my leg, or starts in the chest, but radiates up to the jaw or the arm. S is for severity. How bad is the pain? We can use a pain scale, which we'll talk about in a minute, to describe the severity of the pain. Or you can ask, and sometimes this is really helpful, to describe, are any of the activities of daily living of this patient affected by this pain? That helps describe how severe it is. So, does this pain inhibit my sleeping? Does it make it hard to eat, to cook, to stand, to walk, to climb upstairs, to sit, to talk? The impact on ADLs is really crucial for the nurse to understand in terms of how this symptom affects the patient's life, but it also gets to the severity of it. Maybe it's just a little thing that doesn't really bother me much at all. I'm just wondering what it is and to make sure I shouldn't worry about it. But I can really ignore this. Or maybe it's something that is creating havoc in my life. So that's a really important distinction to make. T is timing. Not just when the pain started, but does it happen in the morning? Does it happen in the evening? Does it happen after a lot of activity? Or does it get better with activity? Did it happen gradually? Did it happen suddenly? Is it constant or intermittent? Does it happen once a week, 10 times a week? And how long does it last each time? Is it for a few seconds, minutes, or hours? Another useful way to organize your symptom analysis is using the mnemonic old carts. You can see what each of the letters stand for, and this roughly correlates to the OPQRST method, getting to the same information. Use whichever method you prefer, or another one. As long as you gather the data and document it well, you're doing right by your patient. One other concept that's really crucial is the meaning of the pain to the patient. So for instance, are they scared that this could mean that they're dying? Are they worried that they've got cancer? Imagine, for instance, if a patient is in labor and they're very excited to have a baby and they're feeling very in control and not at all scared, they're going to have a very different experience of that pain than someone who doesn't know why they're having such a pain or maybe thinks they're dying and has no control in the situation. Another important concept, the more anxious that person is, the more pain they're going to have. The more control they feel they have in the situation, the less anxiety they'll have. The more choices they have in the situation, the more control they'll feel. So, more choices, more control, less anxiety, less pain. Keep that in mind as a nurse as you're going through your patient's journey with them. We can ask our patient to point to where it hurts. Sometimes there's a small point in their body from where the pain is coming. That's called localizability of the pain. Sometimes the pain is a more general area or a larger area or changes a great deal. That means that it's not localizable, and that's another variable related to the location of the pain. We can use a diagram like this one, and the patient can actually show us on the diagram where it hurts. This can be useful, especially if they have multiple areas of pain, if it's not hurting right at the moment, or they're not so flexible and they can't necessarily point to the area that's giving them pain. In order to express severity, we also use something called a pain scale. Say, for instance, to your patient, try to rate your pain on a scale of 0 to 10, where 0 is no pain at all and 10 is the worst pain you can imagine. What number would you give your pain right now? And they might say a 2 or a 5 or what have you. They may say, it's really, really terrible. It's a 3. Or they might say, it's not so bad, it's an 8. That doesn't matter. You record what number they give you. The idea of using a pain scale is so that you can compare a person's pain experience through time. So for instance, if John has pain at 10 a.m. and I give him a certain kind of painkiller, I want to know what his pain is at 10 a.m. just before I give him that painkiller. And then at, say, 30 or 60 minutes when it's hitting its peak, I want another pain reading. I'd like to know how severe his pain is again. And then as that painkiller is wearing off, I want to know where his pain is at that point. So it gives me an idea of how to compare one person's pain experience over time. It is not helpful for me to be using that pain scale to compare two different persons' pain. So for instance, if John and Sue both have the same procedure and John rates his pain at a 5, but Sue rates her pain at an 8, it does not mean that Sue is having more pain than John is. It's not helpful that way. It only helps for me to know whether or not John's pain is getting better or worse or staying the same over time, and whether Sue's pain is getting better or worse or staying the same over time. If someone doesn't understand numbers, for instance, little kids, you can use another form like the smiley face to frowny face scale, and usually that will make sense to them. That's an overview of how to assess pain. There's a reason why pain has been added to the list of what we consider vital signs. Pain is a crucial, fundamental facet of our patients' well-being. As you become professional nurses, this will likely become an integral part of your practice.